my talk was really trying to address some of the controversy that we have in the treatment. Obviously, if we are here and we are having a discussion, it's because there are controversies in this very exciting field. And but I think we can probably address this more in a more streamlined fashion and review it during the debate. Now, first thing first, things don't happen incidentally. So if I have a strong interest in chordoma and musculoskeletal tumors, is because I'm Italian. I was born in Bologna, and Bologna it happens to be one of the leading musculoskeletal centers. That's where I trained. One of the leaders that will always be remembered as innovator in this field. This was my mentor, my teacher. That's where I did my residency program and did an initial fellowship afterwards, and then subsequently I went to the Mayo Clinic, and I've been mentor. Had the extreme pleasure to be under the guidance of another leader, Frank Sim, another innovator, really one of the few people that started the concept of sacral surgery. And then I had an opportunity to join another glorious institution in town where there's tradition of not only of musculoskeletal oncology, but of chordoma in particular. And so it's a great pleasure for me to be here today. And again, on the following my initial training, I was fortunate enough to work when very young, and this is, clearly a very outdated slide from my institution, and that was a project that one of the attending there was to review the sacrum and the sacral tumor, and from that we extrapolated this more recent data. So certainly a large series that gave me an opportunity when I was very young to work and review some of these cases that today we sometimes we considered like prehistoric, when chordoma was basically diagnosed with myelogram, and then finally, and I had the opportunity to review also chordomas of the mobile spine, and at that time we were talking about late 80s, early 90s. Axial imaging was available. From the beginning, we had impression that MRI was going to make a difference. And also, I had the opportunity to have some basic understanding of the pathology, which is so relevant, I think, and that's why I'm spending a minute or so on the clinical radiographic and pathologic characteristics of this tumor. They are so peculiar and so important, I think, to capture the essence of the difficulty in addressing the local regional treatment of this condition. And much of this is really in the mixture and the tumor of solid, but unfortunately more jelly-like, mucinous areas that are hard to capture with simple surgery, with surgery alone, and are even hard to and represent a challenge also for staging as we intended for other type of musculoskeletal tumors, more appropriately solid tumors, and which chordoma not entirely is. And the pathology, and this again, these areas of more fluid that may represent certainly one of the reasons why, at least in the sacral and the mobile spine, leak of tissue is not necessarily detected intraoperatively and may remain undetected by the surgeon, probably explaining some of the failure after so-called negative OR0 margin. Out of that initial experience, the survival curve for chordoma came out of back then a remarkable experience. And from the beginning, many institutions were coming up with the same data, show that debulking was certainly not satisfactory, while instead M block was associated with a better result, with a better local control. And of course, in the subgroup of so-called wide margin, as per tradition in musculoskeletal oncology, today we would say negative margin or R0, the survival is even higher. This is overall, but and it's over a reasonable period of time. Technique has evolved from those days. In those days, essentially all over the world, there was no reconstruction carried out in this setting. I think we have evolved to a large extent in our understanding of functional need and quality of life and a need for surgical stabilization. There's been always this debate between, in particular, the Swedish and the more Southern European and North America on the need for stabilization. But I think the results, in a certain way, have become and more uh, have improved more on the functional and level of activity to a large extent, but not necessarily on local control. And you would imagine that the opposite, perhaps. There have been, additional uh, 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 changes in the field, and in particular, one of the main game changers has been a wider or more liberal use of free flap, which has decreased the historical complication of sacral surgery, which is infection and dead space. But very recently, the international sacral chordoma study group that was essentially trying to address some of the controversy that we're debating today, have come up with a document, with a paper stemmed by a consensus meeting. And anytime clinicians do a consensus meeting, is because the data are not clear. Otherwise, there will not be need for a consensus. The data will speak by themselves. And interestingly, results are still somewhat variable, clearly showing that with a negative margin, you can expect a survival of 5 to 10 years that's probably equal or superior to 50%, with some variability, clearly. One of the reasons the initial paper overestimated the survival and local control was probably because MRI imaging was not routinely performed to detect local recurrence. I think this remains a variable. And so, besides the data, what I think is striking is, looking at this data, is that we know by fact, because these are all friends and group that work across the world, unfortunately, the definition of what R0, R1, and R2 are, particularly R0 and R1, change from institution to institution. They don't change for the AJCC, but they change for the interpretation that pathologists do have. And therefore, clearly, obvious observation is that we still don't speak the same language when discussing this difficult and fascinating topic. A second area of contention or of controversy is that not necessarily the urgency that a surgeon may feel during the preoperative phase and during surgery itself in interpreting the imaging. And so, we often speak about the neoplastic invasion of the posterior rectal wall, but that's really not something, it's not a clear cut. It's not a black and white situation. And, as opposed to the invasion of a mesorectum that is free from disease. And so this remains an area in which more tissue or less tissue is somewhat left to the expertise and, often extensive expertise of the surgeon, but without hard data to guide his choice. The difference from the 90s is that clearly radiation therapy has stepped into the field. The cornerstone of treatment has been always considered surgery, and I still think that surgery is of paramount importance, but certainly radiation therapy plays a much bigger role. And if you look at the data, the outcomes, I think they are pretty good. That's why we say that radiation therapy and surgery, as overall, are equivalent to a large extent. There's not a huge difference. So what are the differences? Well, I think Dr. Yamada already addressed some of them. Who uses photons with intensity modulated treatment, who use heavier particles, who use protons, We are debating whether the Japanese and European experience with carbon iron are certainly not reproducible now in the US, but may be a standard to which look at. But the additional complication is that the Europeans and the Japanese use carbon iron a different way, with different fractionation and even different limit for definitive and adjuvant therapy. So that remains a limit, in my opinion, in fully interpreting these data. And unfortunately, for whatever treatment, being chordoma, a relatively slow-growing tumor, it takes time to get data. So even if we were able to start tomorrow with the best designed trial comparing radiation and surgery, for example, it would take another decade at least to get data. And these trials are very difficult to run. And the reason I show the paper out of the Sacral study is because that's what's happening in Europe. Another area of contention that I'm sure we will review during Q&A is the different way that, based on different modality at different institutions, radiation therapy plan is an extra margin from the primary disease is elaborated for definitive treatment. So how much extra margin we give to gross tumor volume in the clinical target volume is a matter of debate. And again, this is a consensus paper making some suggestions, but all of them are potentially debatable. One area that I think we've always overlooked, I certainly did, and I believe surgeons in general will always sort of ignore or not consider relevant, is that just as osteosarcoma may be associated with skip metastasis, I think we have a better understanding now of what has been described for a long time, this tendency of the tumor not only to leak during resection, but perhaps to seed in a way that is not necessarily captured by preoperative imaging. And so if you don't see it, you don't remove it, and you may end up with a local recurrence, even with a negative margin. That's the inherent limit of the assessment of surgical margin. And this is, I think, has been brought up pretty brilliantly by a relatively recent study, basically on correlation between imaging and pathology, by a large study carried out in Japan, in which clearly they beautifully capture how an otherwise healthy, normal-looking tissue, well distant from the primary tumor, which is in the bottom left corner, and this is striated muscle. You can see from a typical, feature, it has been cut probably about 90 degrees to the direction of the fibers. You can clearly see a nodule of chordoma, and this distance is nearly 2 centimeters. So we often discuss about how margin we should give it, how the gross tumor volume should be extended in radiation therapy. Ultimately, radiation therapy and surgery pursue the same ablative goal and have the same issue, margin and treatment. And that is certainly a confounding factor at the time of surgery and treatment. And this paper also has reported, and that's a different way to assess the biology of chordoma, how the patients that presented intravascular tumor, it's a small vessel, so it's probably in the range of 1 to 2 millimeter, and musculature around the primary tumor. We know that gluteal musculature and piriformis are usually the one that we discuss the most. Well, this clearly demonstrates intravascular tumor, and those patients had a worse outcome. Finally, I think there is an area that I found fascinating, and that's why I was listening with interest, Dr. Yamada. I think hypofractionation in selected circumstances has proven to be very, very effective. Dr. Yamada and I shared several patients that were treated with hyperfractionation, which is, if proven effective, of course, of great advantage for the patient. Single fraction, no need to travel, no need to. In particular, this I think is quite remarkable observation, and maybe it's not for everybody, but I think again the key is understanding that individualized treatment is the key, along with speaking the same language. Finally, I think beyond the typical classic chordoma variants, which are now acknowledged and recognized to have a potential different biologic behavior, I think even rarer variants are certainly associated with the worst outcome. And for those rare variants, traditional approach doesn't work clearly. So these patients have a much worse outcome, in which negative margin often is not enough, even when combined with postoperative radiotherapy. And we have seen, a handful of these patients, unfortunately, succumb to a disease that really behaves in a much more aggressive fashion than classic chordoma. And I think this, I was part for many years of the NCCN panel for bone tumors. I think has been considered for the last at least couple of years as for potential consideration for the emanation of guidelines that may address this differently. The problem is we don't have much to offer, but there are specific and isolated circumstances in which, for example, tametastat can be combined with radiotherapy, and Dr. Yamada and Dr. Gannett have published a couple of cases, I believe. So consider the case for individualized treatment, even for very extremely rare subvariant of chordoma, can certainly be made. I thank you very much for your time.